Welcome to this week's version of Healthcare Insight on America's Web Radio. I'm Ron Bachman, and we've been talking for the last several weeks about creating a private, free market health insurance reform package. We've gone through enormous detail over the last 8 weeks, and we've outlined a number of changes that can be made both legislatively, regulatory-wise, and just the public demanding that and knowing that certain things can be done to improve the use of our health care system by having better health insurance. Remember that Obamacare was mainly around health insurance reform. So if we're going to replace Obamacare, if we're going to change the way the market is, we're going to have to start with health insurance reform. I've talked about the different stakeholders and what each of them would be interested in. And if you go back several sessions, we talked about a number of areas that insurance companies are looking for: broader markets, more stable markets, lower premiums so they can sell their products. We've talked about hospitals wanting to have lower uncompensated care. We talked about brokers and agents who want to have a bigger market to sell. The more products they can sell, the more people who are insured, the more commissions they can make. Consumers, they want to have lower premiums. They want to have access to affordable care that covers pre-existing conditions. All the different players, including physicians, would benefit from having a private free market system that works the way it's supposed to work. We've never had that. Pre-Obamacare wasn't a private free market system. It was heavily regulated. It was regulated at the federal level and the state level, and those laws and regulations weren't written for the benefit of consumers. They were written mostly by insurance company and other healthcare vendor lobbyists, not to the benefit of consumers. So what we tried to structure is a system, a process that would be consumer directed and patient centered. We said you can't really get to good health care reform unless you do health insurance reform. But one of those stakeholders, the physicians, we said if we were talking about real health care reform, we'd have a whole set of other issues. Now, there is one issue that kind of crosses both the health care and the health insurance reform lines, and that is tort reform. Some would call it health justice. If we could get and change tort reform, it would not only change the health care market and the way health care is delivered, but would have an impact on health insurance. So it's the one area that I said that we would kind of hold off until later in our discussion because it's sort of a crossover area that dramatically impacts, or could impact if we did it right, both health insurance and the delivery of health care. Now, what is tort reform or health justice? Tort reform usually includes laws that limit or cap the amount of money that patients can receive as an award from a clinician they've sued for malpractice. Additionally, tort reform caps the amount of punitive damages a judge can order to a physician for a physician to pay. So tort reform puts caps, basically, on the amount of damages. The object of tort reform is to remove unnecessary tests, procedures, referrals, and other medical services done strictly to limit claims of medical malpractice. The medically unnecessary services are typically referred to as defensive medicine. In other words, it's not helping patient get better. It's only protecting the physician in the case of them being sued, that they could say they've tried everything. Because, there's nothing worse than being on a witness stand and you're being sued. And the suing attorney says to you, have you tried everything to help my client? You said, yes, I've tried everything reasonably possible. They say, well, what do you mean reasonably possible? Well, there's a lot of outside possibilities of things I could have done. Well, did you do that thing that was right 0.5% of the time but cost $50,000 to do some tests and follow-ups? No, that didn't seem to be worthwhile at the time. You've just lost your lawsuit. You maybe have lost millions of dollars and maybe even your license to practice. So defensive medicine has been around for a long time and is almost built into our current system. And it is pernicious. It is destructive of the cost of medicine. It's destructive on the delivery of appropriate care. And it doesn't necessarily help the patient because more medicine is not necessarily better medicine if you get the wrong kind. Because defensive medicine practices are taken solely to avoid medical malpractice claims, it's an ideal place for them to be reduced, to reduce the cost of health care and reduce the cost of health insurance. Trial lawyers and class action lawsuits have changed how health care is delivered. Some estimate excess costs of at least 5%. As the tort reform, trial lawyers and class action lawsuits have changed dramatically how the health care is delivered. Defensive medicine, let's talk about that for a minute. There's a study that's based on a survey believed to be the first of its kind that was completed by more than 900 physicians in Massachusetts. It asked about their use of 7 tests and procedures: plain film x-rays, CT scans, MRIs, ultrasounds, laboratory testing, specialty referrals and consultations, and hospital admissions. About 83% reported practicing defensive medicine, with an average of between 18% and 28% of tests, procedures, referrals, and consultations, and 13% of hospitalizations ordered for defensive reasons. A study conducted in 2005 received responses from over 800 physicians in 6 specialties, with approximately 93% of doctors responding affirmatively when asked about whether they practice defensive medicine. So we talked about defensive medicine is pervasive. It's going to be very difficult to even get it out of the system if we have tort reform, but we have to start. It may take a while to change the delivery of medicine, of doctors feeling comfortable not ordering these unnecessary tests, but the sooner we start, the better. It's a difficult task to get legislation passed at the state and federal level to really do tort reform. But there are options. To achieve tort reform, mechanisms that would reduce, if not eliminate, many of the drawbacks in our current legal system must be passed. There might be aspects in some of them that would not appease Republicans or even Democrats. 3 ideas that are being increasingly circulated around tort reform. The 3 concepts are explained in the New England Journal of Medicine Perspective by attorneys Michelle Mello, M. Phillip, and Troy N. Brennan, who is also a physician of the Harvard School of Public Health. The first option, medical courts. Medical courts are also called health courts, and they're judicial systems similar to many other types of specialty courts, where medically proficient specialist judges decide only on cases related to malpractice. There would be no juries, and thus no potential for attorneys to sway verdicts on the basis of theatrical, emotional oratory. Similar courts operate to decide cases involving specialized areas of mental health, behavioral issues, bankruptcy, drug addiction, workers' compensation, tax delinquencies, and many other kinds of troublesome legal issues. And these specialized judicial systems are generally regarded as a success for a variety of practical reasons. Mainly, these judges know complex medical treatment issues far better than their counterparts who may rarely be assigned such a case. Expansion of disclosure and offer. Disclosure and offer is another option in which providers would disclose the occurrence of caregiver-caused events that brought harm to patients and their families, and would promptly make offers of compensation. Parties may or may not waive their rights to sue, but in theory they would not. The Harvard author said that while he was a senator, Obama co-sponsored legislation to promote this approach. The third option, utilization of care standards created by the Federal Coordinating Council for Competitive Effectiveness Research. They created a $1.1 billion in stimulus funds that could create safe harbors for physician and hospital practice that adhere to them. If providers abided by these evidence-based guidelines, they would have safe harbor from liability. This kind of tort reform might even go further than pay for performance experiments that are getting providers to comply with best practices. So if they do best practices, follow evidence-based guidelines, they would be exempt from liability. This strategy was incorporated in the bill to establish the Healthcare Overuse Reform Today Act, or the Health Court Act, by Representative Tom Price at the time. He's a Republican from Georgia. The safe harbor would apply only to those physicians who abide by those nationally recognized standards of care. This strategy might avoid the expensive practice of defensive medicine, in which providers order a lot of costly, unnecessary drugs, tests, and procedures out of fear they will be sued if somebody decides, in the absence of such care, they were caused harm. Defensive medicine spurred by concern about malpractice liability is a substantial driver in the escalation of healthcare costs, wrote Milo, Phil, and Brennan. These costs are notoriously difficult to estimate, they added, but trimming even 1% of total healthcare spending would save around $22 billion a year. So health reform would include tort reform. Health insurance reform would heavily rely on lower costs from tort reform. Well, I hope you can see how some healthcare reform that can be easily done in conjunction with health insurance reform really can have an impact not only on the cost of health care, but the cost of health insurance, and be to the overall benefit of the consumer, the patient, who just wants the best care at the right time, in the right place, at the right cost. Surely, following the principles of MAGA Health and the details that we've laid out over these last several weeks, we can accomplish this if we really want to. As Republicans move forward, as those who believe in free markets move forward over the next 12 months, before the next election, we've got to do some experimenting. We've got to have some states that will step up and actually try some of these ideas. The White House, HHS, is desperate to find some states that will actually implement this so that it can be used as an example and spread across the country. Not going back to the high-risk pools of the past, but going to an impaired health support group where we help the sickest among us. And with tort reform, we can not only help the sickest among us, but we can do it in the most cost-effective way possible. Well, it's time for a break. Let's come back in a few minutes and continue our discussion on how to create a private, free market health insurance. Welcome back to America's Web Radio. I'm Ron Bachman, and this is Healthcare Insight. We've been talking about creating private, free market health insurance. We've been through an awful lot of detail on how that would work, how it would be structured, the new entities that would need to be developed, the new rules and regulations that would be simple in nature, but necessary to create a structure around a free market system that is consumer-directed, patient-centric. We're now down to talking about some of the consumer-oriented state insurance laws that could be implemented to support the whole structure that we've been describing over the last several weeks. The focus of what I've called MAGA Health involves reforms to individual and small group health insurance. As we've said many times, we need to do health insurance reform so that we can get to better health care. Health insurance is how we finance health care. Health care is the services we get from the providers of hospitals and doctors and medical providers. But individual and small group plans, these plans have historically been controlled by state laws. Obamacare overrode many of the state controls. Once Obamacare is repealed, the states will once again have to regulate individual and small group plans. So the whole idea of MAGA Health is to create that framework that with or without Obamacare, we can make major reforms to lower the cost, improve the quality, and increase access to individual and small group health insurance. If Obamacare is repealed, this entire structure will work very efficiently and ultimately the best approach to accomplish those benefits that I just described. If Obamacare is not repealed, there's something called a 1332 waiver that would allow states more flexibility in establishing rules and regulations and access to government funding that would help support better individual and small group plans. So the following is a list that we're going to go through of state changes that support consumer-oriented state laws. Not all these ideas will relate to every state. State officials should study and apply those changes consistent with their specific existing laws. One of the problems we have is that we have 50 states with 50 different sets of rules and regulations and laws that govern individual insurance and small group. So each state's going to have to do something a little bit different. Some states can apply all of these rules and regulations that I'm going to suggest, all these changes. And other states might not be able to do them or may have alternatives. But the whole idea is let's have choices. So what I put together is a list of ideas, and I call them flexible choices. The flexible choices were developed over several months in consultation with the Georgia Department of Insurance lawyers and staff. I'm originally from Georgia, where I've spent most of my time with the state legislature, with governors in the state of Georgia, and with the Department of Insurance. As an outsider, I had a lot of relationships and friendships and the credibility to be able to work with all those entities. We actually went through the Georgia Insurance Department rules, laws, regulations, and reviewed them in an attempt to make them consumer-oriented. The reality is that most state laws were developed by insurance companies through their lobbyists and their lawyers. Consumers rarely had a chance to actually develop the language, the balancing, if you will, between individual rights and business interests. Most times, consumers had no idea what was really being passed, and it was usually a fight between lobbyists. Maybe there were consumer advocates, but most consumer advocates, quite honestly, don't even want states to regulate. They want a centralized, single federal government solution, like Obamacare, like Medicare for all, like single payer system. So they really weren't that interested in fighting for the consumer at the state level as state laws were being considered. We scrutinized the Georgia laws for areas that could be made more beneficial to consumers. So let's go through and talk about these flexible choices. As I said, most state insurance laws and regulations were either written or heavily influenced by insurance industry lobbyists. State insurance commissioners, either elected or appointed, have done a great job in regulating the insurance industry. However, consumers rarely have had a direct voice in writing laws and regulations. Most consumer advocate groups tend to be liberal organizations who propose more government control and federal oversight of insurance. Each state has differing laws and regulations, as we've already said. Many of the consumer-oriented changes for small group fully insured plans were developed for Georgia, but have application in most states. So let's talk about some of those changes. First, concierge services. It's becoming very popular across the country. Some states already allow it. Some states need to have enabling legislation. Under reform legislation, physicians should be allowed to enter into direct financial arrangements with their customers for specific services and not be subject to insurance laws. Technically, if you receive money for medical services, that could be considered a premium, and you'd be considered an insurance carrier, and you'd have all sorts of new laws and regulations that would apply to an insurance company that really shouldn't apply to a physician that's providing services for a fixed monthly fee. You can put a limit in if you want. You can say if the services are less than an annual amount to be determined by the legislature, then they wouldn't be considered, or you can just leave it open and look at the activities and the extent of the services that are to be provided. Under existing law, a fixed price or a capitation rate for specific services could mean that a physician would need to satisfy all the insurance laws, and that just doesn't make any sense. So if you expanded and allowed for concierge services in a state, what could the cost impact be? Well, the cost impact would be a lowering of roughly 2 to 3% by my estimate, or more, as a higher deductible insurance could be selected with a special services contract for a specific current condition. In addition, a concierge option provides choice for consumers who want specialized or personalized health care from their physicians. Basically, it would lower premiums by at least 2 or 3%, maybe even higher, and basically allow people to buy higher deductible plans, which would be much lower cost. Well, what most people don't understand is that if you are fully insured, we described the difference between fully insured and self-insured plans before. Fully insured plans are the traditional way individual and small groups get their insurance coverage. And most states have something they call a premium tax. It's really a sales tax. Originally, this sales tax was called a premium tax. Were added to homeowner insurance plans to compensate states for fire and police home protection. It was never originally done for health insurance. The legislators saw the ability to raise taxes, so health premiums were added years before any health insurance became so expensive. But once insurance became expensive, we said everybody ought to have access to more affordable care. There's no reason to artificially add to the cost of insurance by adding this sales tax onto it. So today it adds costs and increases the uninsured without any added value. Reform legislation eliminates premium taxes on individual and group comprehensive major medical plans. You want to eliminate it on all health insurance plans? Great. Let's eliminate it on at least comprehensive health care plans and HSA eligible plans. Those should be the most affordable plans that we really focus on to try to get more people insurance at the lowest cost. Reform legislation eliminates the premium tax only on the state portion for those insurance policies because we can't eliminate it on federal without federal legislation. So if states are trying to do this, they can at least eliminate it on the state. So if you have a state premium tax, that eliminates a good bit of cost. And if you make the premiums for these selected plans not subject to your state tax, then you save even more and lower the cost. For example, Georgia has basically a flat 6% income tax. Well, you take it off of these plans, they become that much more affordable. So what's the cost impact by taking away the premium tax that we first talked about? Well, it would lower by on approximately average across most states about 2.25% on major medical plans or HSA eligible plans if you included them, or the same amount if you included all plans and eliminated premium taxes on all those. It gets a little complicated because premium taxes actually can be developed by local cities, local counties. The state itself would usually collect it and then distribute it back. Some of it may go into general revenue. So there's a lot of special interests that don't want to give this up. But if you have a governor, if you have leadership in your congressional delegations and you're really committed to this, it makes a lot of sense. and it's hard to deny lowering these premium taxes that are really unnecessary, lowering them and making premiums that much more affordable. Another area is allowing what are called exclusive provider organizations. Exclusive provider organizations, or EPOs as they're sometimes known by the letters, only cover services in-network providers. In other words, there's no out-of-network providers, with the exception for emergencies, with the exception that if the network providers are inadequate and can't provide the service, then you can go out of network. But in-network provider costs are typically lower and more stable because of pre-negotiated fees, agreed upon medical procedures, and medical reviews that set appeal processes. Many hospital systems, large hospital systems that have all the network capabilities, may contract with insurance carriers outside, but many of them offer their own network of physicians to their own employees. So you have to use that hospital's providers unless they don't have those doctors or services available. Then you can go outside and those get reimbursed. But many large employers in cities where there are significant medical facility services available prefer to go with an exclusive provider organization because they typically have the lowest prices. As I said, emergency services are considered in-network regardless, and providers and services not otherwise available in network are covered as in-network. EPOs are growing in popularity and interest among large self-insured plans. This legislation allows fully insured plans to offer similar plans to small employers. Right now, EPOs are typically only available to large self-insured plans. So what's the cost impact of EPOs? Well, studies have shown the EPOs can lower the cost of insurance by 5 to 6% or even more. So you start to build all these different cost savings from concierge services, removing premium taxes, and allowing EPOs. If somebody is taking advantage of all these, you can see that these 2, 3, 4, 5% kind of build on each other and lower the overall cost of healthcare. There's several more that I want to go through in the next section. So let's take a quick break, and we'll be right back and talk about some more ideas on how to make individual and small group plans more affordable and add to the ideas about creating MAGA Health private free market structure. Welcome back to America's Web Radio. And the program that you're listening to is Healthcare Insight. We've been talking over the last 8 or 9 weeks now about how to create a private free market, a health insurance that provides consumers with guaranteed issue, with coverage of pre-existing conditions, which does it in a very market-oriented, consumer-oriented, patient-centric way. It's an idea that those who believe in free markets can study, can learn from, can build into any alternative programs they want to put together. It's a great program for elected officials who want to change some state laws, who want to apply to the federal government to improve the individual and small group health insurance markets in their own states. And what we're going through now is a series of considerations that I've called flexible choices. So let's continue through as we had in the last section and talk about some ideas and the potential cost impacts and the way we can lower premiums and make insurance more affordable, cover more people for the care that they need. Well, let's talk about health improvement incentives. This change expands the ability of insurers to provide financial incentives to plan members who are compliant with healthy initiatives. Outdated rebate laws prevent insurers in many states from providing incentives that have shown to be improving of health, lower unnecessary and unneeded use of medical care, and improve the quality of services received. Incentives can be offered for wellness, condition management, disease management, and health improvement programs. Incentives can include merchandise, gift cards, debit cards, premium discounts, HSA contributions, co-payment reductions, deductible reductions, co-insurance reductions, or lower premium contributions from employees. There's no reason that those who are offering up products, the risk-bearing entity in this case for small employers, small groups, and individuals, it's the insurance companies that have the risk of higher claims. So if their customers, the policyholders, are doing the right things, changing their lifestyle, following their doctor's orders, taking their medication, doing all the right things to either stabilize the health condition they have or to improve and recover, there's no reason why those customers doing the right things that ultimately are saving the insurance company from paying out medical claims, why those customers shouldn't have some reward and incentive to reinforce those good behaviors. Now we're seeing more and more of this as it sort of inches along because it's so logical. There's not any reason why that wouldn't be the case to reinforce good behaviors. But in this fully insured small group and individual market, many state laws prohibit the use of these kinds of incentives from something they call rebate laws. In the old days, insurance agents would sell a policy and then rebate some of their commission back to the policyholder. That became illegal. So it became illegal to provide a financial incentive to the consumer after the sale of a policy. Well, that was in the old days. There's no reason it should be that today. Large employers, large self-insured employers aren't governed by those rebate laws because there is no insurance agent involved. Typically, large employers use consultants that they pay on an hourly basis, so there's not a commission involved. So they get the benefit in the large group market. So we know what the benefit is. We know how valuable it can be to change employee behaviors, to increase compliance with care, and to reward and incentivize people to do the right things, to reinforce that good behavior. Well, what's the impact? It allows fully insured small employers that are state regulated to benefit from the cost-effective incentive strategies proven to lower costs in large self-insured plans that are covered under ERISA. So it shouldn't be that, well, one's state regulated and one's federal regulated, so the federally regulated large plans get to have these great benefit designs. We should make that available across the board, and we need to change some state laws in order to do that. Well, what's the cost impact? Well, the cost impact is enormous. We've seen in large groups how effective it can be. That incentives can lower the cost of insurance by 20% or more, providing incentives up to the federal Department of Labor limits of 20 to 30% of premiums for health status incentives and unlimited incentives for participation rewards. So health status incentives would be things like lowering your blood pressure, cholesterol, removing nicotine use, A1C stabilization, waist size measurements. We know what all those things should be to have a healthy employee or plan member. And large employers are allowed to do that and get lower costs from that because the employer is the risk-bearing entity there. And if the employees are doing the right things, the employer is the one who saves money, and they're allowed to share some of that savings back. There's no reason why insurance carriers offering to individual and small groups can't do the same thing and reap the same benefit of lower premiums. Well, let's talk about another idea that's percolated recently, and it is something that I will call a small employer tax credit. And that is to encourage startup and small businesses to provide health plans, small and startup employers, and you can use some number. I'll just say 10 or fewer employees. It might actually be 25 or fewer or 50 or fewer, but pick a number if you're a state legislator trying to write this into your laws. Because if a small employer starting up can be encouraged to buy health insurance for their employees, it's very difficult for them to take it away. They'll find the value and the benefits in recruiting and overall productivity, fewer unscheduled sicknesses and absences from work. So it benefits everybody, but small companies, small employers starting up, that first year of business, it's awfully tough to add health insurance when they're just trying to survive. They've got limited capital. They've got to focus on trying to make the business work, and then later on, they'll add health insurance. So the sooner we can do that, the better. So providing a small employer tax credit would be something along these lines. Allow a $250 tax credit for each employee enrolled in a comprehensive major medical plan if the employer pays at least 50% of the premium and the insurance is made available to all employees. Now, I'll tell you what we did in Georgia in 2008, pre-Obamacare. Existing Georgia law from that time actually allows a tax credit for HSA eligible plans only for groups of 50 or fewer employee lives. It was a great way under Georgia law to actually encourage the use of HSA eligible plans. Then Obamacare came in, and quite honestly, the insurance companies never fully picked up on this great benefit for allowing a tax credit to small employers who would offer up insurance during their first years of existence. In Georgia, we said the tax credit is limited to 3 years. The tax credit opportunity will expire 10 years from the legislative effective date. So we put a specific time for how long you would get that credit, and then we actually put a time period as to when the passage would be effective, so it wouldn't go on forever. Well, we're now more than 10 years away, so this would have to be reinstated in Georgia if plans and insurance companies would actually take a benefit from this. So what's the impact of something like this? Well, it makes group health insurance more affordable for small and startup businesses in the early stages of development. Early adoption of insurance in this job-creating market segment will allow job creation as potential employees are freed from job lock for insurance in larger existing employer plans. Many employees would like to go to work for startups. Many employees would like to go to work for a smaller company where their skills would be highlighted and extremely valuable to a smaller company. But their job lock, or they look for jobs originally in large companies because they know they can get insurance there. So if there's no insurance available in a small company, it makes it very difficult for somebody to take that job, even if they're paying more in salary because of the benefits of insurance. People stay in large companies. So what could be the cost impact of moving along these lines of offering up a small employer tax credit? Well, the cost impact for employee-only coverage, so just take the single employee, it lowers an employer's net total employee premiums by up to 5.6%. If applied to an employer's contribution, the tax credit lowers an employer's contribution for employee-only coverage by up to 6.5%. If applied to an employee's contribution, the tax credit lowers an employee's contribution by up to 42%. So depending upon obviously the cost of the insurance, the tax credit has a different relationship to the cost without the tax credit. But obviously it can do an awful lot. As far as family coverage, it would lower an employer's net total family premiums by about 2%. If applied to an employer's family coverage contribution, so the employer's contribution, the tax credit lowers an employer's contribution for family coverage up to 2.5%. If applied to an employee's coverage contribution, the tax credit lowers an employee's contribution for family coverage by up to 8%, a little bit more. So it has a benefit for both the employer and the employee if that savings is shared across the coverage for both the employer and the employee. Now, let's go to another idea. Any willing preferred or exclusive provider. If an employer group changes plans to either a preferred provider or an exclusive provider organization, a member's doctor can continue to treat them. So if you change insurance companies, what you want to have is if you got your doctor, you can keep your doctor. You know, that falsehood, that lie about Obamacare. Well, in the past, insurance companies really didn't want to open up the door to any doctor who wanted to offer up continuous care if they weren't in the network of the new insurance company. They wanted to cut deals with a more narrow network, but those were when it was very difficult to establish a network. And you had to have that kind of guarantee or incentive of moving people into a specific network. Well, networks exist all over these days, and most of them are combining, and they're very large, and they're not as exclusive as they used to be. So if your doctor's not in a network, let's say you're with Aetna and you move to Humana, but Humana doesn't include your doctor because they have some other restrictions. Well, if a doctor is not part of the new plans network, the doctor can apply to be in the network if the doctor agrees to the standards of the insurer's network. So in other words, if the doctor is willing to take a lower payment, if that's the case, or have some other oversight requirements, if that's the case, the doctor typically will want to keep his own patients and not lose them to an insurance company. Doctor may not, but at least that option is there under this kind of any willing provider legislation. Let's stop here. Let's take another break, and we'll be back just a minute for the next segment of Healthcare Insight on America's Web Radio. Well, let's go back in this section to that any willing provider, because it's a real important piece of potential legislation that ought to be passed in every state so that people can keep their doctors, the doctors can keep their patients, and we can unify that most important patient-provider relationship. So let's go back and recognize what it is we're talking about. Allowing doctors who may not be in a carrier's network to be given access to that network when their patients change insurance companies. It's real important so that we have continuity of care, especially for somebody who's in the middle of care and treatment. So let's go back and clarify some of the issues and add a little bit more detail to the any willing provider discussion. Insurers are not required to admit providers if they can demonstrate that the inclusion is adverse to the quality of services they provide, or the inclusion will increase premiums. So in other words, the insurer, even if there's an application from a doctor who wants to get in their network and wants to retain their own patients, the insurer is not required to admit them. But the burden would be on the insurance company to prove that it would be adverse to the quality of services and provide an increase in premiums. And who would be the mediator in that? Well, the mediator would be the insurance commissioner. Both would have to submit information if they were not able to come to an agreement. It's just not fair to patients. Again, that law was not written for the benefit of consumers. It was written for the benefit of the insurance companies. Let's do another one. Defined contribution plans. This has been something many politicians have been talking about for a long time. Defined contribution plans would be encouraged under this kind of legislative change by clarifying past legislation that health reimbursement arrangements only, HRAs, are not insurance under state laws. Now, the federal government has made some changes recently under the Trump administration that opens up the door for states to offer up HRA only plans under Obamacare. But if Obamacare goes away, states may need to actually pass laws that would allow for this, because HRAs under federal law, other than the Trump administration's determination under Obamacare, under federal law, HRAs are actually insurance plans. And HRAs are simply employer allocations for an employee to use in paying for healthcare expenses. So they're not real dollars, as we said, like HSAs are. HRAs are allocations of money that an employee can draw on, monies that are held by an employer or sort of noted in an accounting process to pay for things like office visits or prescription drugs or health insurance premiums. In addition, this type of legislation makes clear that accommodating the collection, packaging, or submittal of HRA funds for the purchase of individual health policies by a small employer does not constitute the establishment of a group plan. If in some states there's some special meaning of being a group plan that would be adverse to the benefit of an employer doing a defined contribution plan using HRA funds, if that is a problem, then the state legislation should make sure that offering up HRA funds and gathering up the money to submit sort of a payroll deduction process does not establish a group plan. So what would be the impact of doing this? Well, it can significantly lower the number of uninsureds by allowing alternative funding when employer financial support is limited. Small employers could provide premium support for the purchase of portable individual insurance policies, even if they cannot yet afford to provide for a higher level of contribution typically required when offering a group plan. So that small startup company that we've been trying to say, let's find a way to get those baby groups, those small group employers offering up some level of support of health insurance. This is a great way to do that. So they can at least take some step and say, I'll offer up at least $200, $300 a month per employee, that they can do that without worrying about the future costs or putting themselves in a position of guaranteeing defined benefit plans going into the future when they've not yet established themselves as an ongoing business. Multiple employers. If you're in that small group market as an employee, you might work for several companies. And so multiple employers can contribute to separate HRAs that could then be used to cover the full cost of an individual policy. So it's a great way for somebody who has multiple jobs. If those multiple jobs have employers that are contributing to an HRA, those different HRAs from 2, 3, 4 different employers can be used by the same employee to provide coverage for themselves and or their family. So expansion of defined contribution funding allows for more individual plans and provides for portability, not available even under group or small group plans. Well, here's another idea around changing the tax structure. That is, for comprehensive major medical plans, or at least HSA eligible plans, to make that premium tax deductible on the states. So this would be applicable to states with state income taxes. If your state doesn't have any state income taxes, then this particular idea doesn't go very far. But states can't obviously change federal tax law, but they can minimize tax differentials between individual and group plans based upon the taxes in a given state. You see, just as a reminder for those listening to this, that if you have a group plan, whether it's a small group or a large group, the premiums that are paid by the employee contribution and the premiums paid by an employer, they are tax deductible expenses for the employer, and they're not taxable income for the employee. That's not true if you buy an individual policy. So there's a big difference in the cost of insurance based upon tax law if you buy an individual versus a group plan. So under this idea, individuals with comprehensive major medical plans or HSA eligible plans, if that's the direction the state wants to go, would be allowed to deduct the individual premium costs from their state taxable income. From the state perspective, this provides individuals with equal use of pre-tax dollars to purchase health insurance. It's very valuable to use pre-tax dollars because after you take out 25 to 40% of your earnings and pay income taxes on it, you have fewer dollars left to actually buy those things that you need: food, clothing, shelter, and insurance is rapidly becoming equivalent to those. Certainly the level of the cost of insurance is becoming a major expense for any family. And when it becomes a major expense, there ought to be some way to do that on a pre-tax basis. And if you work for a company and the company is providing a group plan, that is true. You do get the pre-tax use of dollars. There's no reason why an individual can't have that same benefit. So what's the cost impact? Well, obviously it depends upon the state income taxes that we're talking about and which state we're talking about. But as an example, in Georgia, there's basically a flat 6% after a deductible amount, a flat 6% state income tax. Well, that means that your premium cost is actually lowered by 6% just by making this on the individual side equal to a group pre-tax dollars, at least at the state level. So that is a pretty significant lowering of the cost of health insurance, makes it available to more people. Well, let's talk about one other thing, and this again depends upon where your state is currently. And that's talking about a minimum out-of-network coverage. If there is out-of-network coverage, those services are typically provided by what are called non-preferred providers or out-of-network coverage providers. And in Georgia, as another example, and this may be true in other states, that those services cannot be less than 50% of the benefits under the policy. So in other words, if you're paying 80% for a service for an in-network, you cannot pay less than 50% for benefits that are out of network. Now, Georgia allows for only a 30% differential between in-network and out of network. And that's fine if you're paying 80% for in-network, you then pay 50% out of network. But what if you wanted to provide a better benefit, or your incentives were such that if you did certain things, your in-network was paid at 90% or 100%? Well, that would mean automatically under the Georgia type of legislation, where there's only a 30% differential allowed, that your out-of-network reimbursements would automatically go up as well. So that if you're paying 90%, you have to pay 60% out of network. Or if you made a change because of rewards and incentives that you were paying 100%, you then might have to pay 70% out of network. Well, that makes no sense, that if you want to design a plan that actually rewards or incentivizes people or gives them more for being in network because you've cut better deals, your reimbursements to doctors or hospitals are at a especially good rate so that you're able to have a better benefit under your insurance policy and pay 90% or 100% for certain services, you shouldn't have to also then provide an increase in your non-preferred providers. So what's the cost impact of this kind of an approach? Well, plans who have these state laws, plans can lower premiums by 1 to 2%. For that change in the Georgia law, for example, that goes from a minimum of 60% to a minimum of 50%. Second, plans can now offer more options and complete coverage with 100% for preferred providers without having to increase non-preferred provider reimbursements to 70%. And third, this allowed out-of-network change is consistent with most other states and less restrictive products offered in other states. Not all states, each state's going to be different again. So you have to take a look at your state law. But take a look and be sure that the insurance companies haven't artificially increased premiums by requiring some level of higher reimbursement for non-preferred providers. Now, all these 1 and 2% that we've been talking about in these ideas, they add up because you don't have to do one without the other one. They're not always overlapping. They actually are distinct. So you can almost add up these changes, the 1, the 2, 3, 5, 6, 8% differentials we've described, and have a significant lowering. If you just had creative people putting together products and putting together networks and putting together systems, changing state laws so that they're consumer oriented and not written by insurance company lobbyists and lawyers. So that's what we've really been trying to do here. Been trying to put together something that actually works for the individual and for small group plans. Well, I know we put a lot on the table. We've talked about a lot of system changes to implement a concept that I referred to as MAGA Health. We put together a lot of detail and concepts that states can do to put together ideas to lower the cost of healthcare for individuals and small groups. And from the very beginning, we've talked about that's the area. The two biggest things that we've been trying to get across in the last 9 weeks now is how do we create a system that will benefit individuals and small group purchases of health insurance. That's where most of the uninsureds are. The other overriding issue, main principle, is how do we treat the sickest among us? How do we get them the best care and treatment to deal with whatever maladies of life that they are suffering from? A pre-existing condition, It may be a chronic and persistent condition. It may be something hereditary. It may be something genetic. Whatever it is, that's the system we've been trying to put together. So if you want to hear more about these details, this whole structure we've been putting together, it's all available on americaswebradio.com. Go to programs, go to Thursday at 11 a.m., and then scroll down my bio to the very bottom, and every week this presentation will be available down there. The alternative is to go to healthcareinsight.net, and all the audio and videos are available on that website. Well, we're at the end of another week. Join me again next week on Thursdays at 11 a.m. here on America's Web Radio. Looking forward to seeing and talking with everybody again. This is Ron Bachman with Healthcare Insight.